In the hospital setting, in the last several years, we've learned that the use of insulin is the most appropriate therapy for our patients. However, we are learning that many patients that don't come with severe hyperglycemia may be treated with other approaches. So recently we've been learning that the use of oral agents might be indicated for those patients that come with mild hyperglycemia, for example, the use of DPP-4 inhibitors. So there's a few randomized trials that have shown that there's a benefit for those patients with mild to moderate hyperglycemia. There's still challenges for the management of patients with nutrition therapy for those patients receiving tube feeds or TPN. Those are very hard to treat patients. There's not a lot of research in that area. There's a recent study with closed loop in patients with receiving nutrition therapy in the hospital. And those are encouraging findings from a group in the UK where they show that those patients assigned to closed loop therapy, a large proportion of them were able to meet targets. Always there's problems with the timing of glucose measurements and insulin administration in the hospital. So those are several challenges. And we're trying to improve the way we do that in monitoring glucose. We're trying to implement technology in the hospital. We're doing studies with CGM. We're trying to measure accuracy, etc., and see what are the challenges in the hospital. So there's still several areas that we need to cover. So the study with Glargine U300 was designed to answer this question about how do we do with patients that are already treated with this insulin when they come to the hospital. Should we stop this insulin and switch them to our kind of standard of care, typically with a basal insulin, shorter acting insulin, or should we just continue? And the next question is, how do we adjust this insulin in the hospital, daily, or should we wait 2 or 3 more days? So that's one of the questions. And the other one is about the risk of hypoglycemia. There's this idea that these longer acting insulins might be associated with a lower risk of hypoglycemia. So we conducted this trial to basically answer those questions: efficacy and safety and risk of hypoglycemia. So we found that the insulin, as any other insulin, is as effective as standard of care. So patients improve the glycemic control similar to Glargine U100. And we learned that those patients assigned to Glargine U300 had lower risk of clinically significant hypoglycemia, 6% versus 0% in U100. Any insulin, the risk is always hypoglycemia. In this study, we learned that patients that come in with high hemoglobin A1C to the hospital are very hard to treat. And this happened to both arms. They came with A1Cs more than 9, with very high glucose levels. And we reached target in only about 50% of our patients, meaning that patients that come with high glucose levels, high A1C, are harder to treat. So I think the challenge is it's still the same with this or any other insulin. We need better strategies for those patients. Let's start with contraindications. In terms of contraindications, and in general, is the same as any other insulin. So maybe patients with the highest risk of hypoglycemia don't really need a very aggressive approach with insulin. I will avoid the use of insulin if possible. There's newer agents that have a lower risk of hypoglycemia. But maybe the indication is for those patients that need insulin and have a highest risk of hypoglycemia, maybe overnight hypoglycemia or hypoglycemia unawareness. So trying to reduce the risk of hypoglycemia when we need to use insulin. So those will be the patients ideal for that.